I'd now like to welcome Dr. Squires from the Movement Disorders Clinic at the UBC Centre for Brain Health. Dr. Squires is the co-medical director at Pacific Parkinson's Research Center and also a clinical assistant professor at UBC. Dr. Squires, welcome and thank you for being here today. I'll pass it over to you now.
Thanks, Elena, and welcome everyone to our second new diagnosis workshop. It's hard to believe we did this a year ago, just before the pandemic started, and it feels like about 50 years at this point. So this is the first time that we've done this in a virtual format. So certainly welcome any feedback around that as well. So today, this is the outline of the new diagnosis workshop altogether. So over the next few lectures, we're going to cover all of these topics. I'm going to do the first 4 boxes today. So we're going to go over what Parkinson's disease is, how common it is and what causes it, how it's diagnosed, and some of the more common symptoms. And then Dr. Mackenzie is going to talk to you about treatment and anything related to treatment tomorrow. And then our wonderful physiotherapist, Michelle, is going to talk about exercise and some tips of living well with Parkinson's disease. So moving right along, Parkinson's disease was first diagnosed by James Parkinson a little over 200 years ago. He published this essay on the shaking palsy based on his observations of people he saw walking through the streets of London, essentially. So what do we know about Parkinson's disease now, 200 years on? So Parkinson's disease is one of the neurodegenerative disorders, and this is a family of disorders that's characterized by slow death of certain populations of brain cells or neurons. In Parkinson's disease, one of the important populations that is slowly dying away are brain cells that make a neurotransmitter called dopamine. And we'll talk about that more on the next slide. And there are specific proteins that build up in the brain cells that are called Lewy bodies that are sort of the pathological markers of the disease, though it's not clear whether they themselves are the problem or more just a side effect of the problem. So dopamine is a neurotransmitter, which is a chemical messenger that the brain cells use to talk to each other and send messages. It's important for control of movement, importantly for our discussion around Parkinson's disease. It also has some roles in mood, so it's one of the good mood neurotransmitters. It's also one of our reward transmitters, so it's involved in addiction, for example, and it has many other functions in the brain. So in terms of what causes Parkinson's disease, 200 years on, we still don't really know. Unfortunately, we do know that a small subset of people have a genetic cause, so somewhere in the ballpark of around 10%. This is most common in people who are younger at the time of onset, particularly those before 50. And in general, the younger one is when the symptoms start, the more likely it is that you're going to find a genetic cause. These people usually have a strong family history. However, there are what are called recessive causes where you need one copy of an abnormal gene from each parent. And so you may not have a family history in those cases. And often the youngest onset patients are those who have these recessive genetic conditions. But that leaves the majority of people with what's called idiopathic Parkinson's disease. And idiopathic is basically science speak for we have no idea, essentially, what causes it. We do know a lot about risk factors for Parkinson's disease, however. So age is the biggest risk factor. Men are more likely to get Parkinson's than women. It's around 2/3 to 1/3, the breakdown. People who have had recurrent head injuries over time, like boxers, have a higher risk. So think of Muhammad Ali, for example. Interestingly, people who live in the country are more likely to get Parkinson's than people who live in the city. Again, the reasons for that are not entirely clear. And then having a family history, even outside of a genetic cause, increases your risk by about 2 to 3 times. And that sounds scary, but as we'll talk about, the risk is low to begin with. So basically what we think of as the cause for Parkinson's is it's probably some mix that's probably different for everybody. So different environmental factors, exposures, potentially heavy metals in the groundwater if you drink from a well, which is a risk factor, pesticide exposure if you live in an agricultural area, for example, We don't know. And then in addition to the genetic causes, it's quite probable that there are genetic risk factors, so certain changes in genes that increase your susceptibility to the environmental factors, and all of this combines together to result in Parkinson's disease. So how common is Parkinson's disease? So it turns out it's relatively common. It's actually the second most common brain condition after Alzheimer's disease, the second most common neurodegenerative disorder. Alzheimer's is also a neurodegenerative disorder. And about 5 years ago, we estimated that there were about 13,000 people with Parkinson's in British Columbia. So fairly significant numbers. And the graph at the bottom is the distribution based on age. So you can see it becomes more common as people get older. So now that we know a little bit about what Parkinson's is and how common it is, how do we diagnose it 200 years after it was first described? Well, it turns out that the diagnosis is still clinical. We haven't come up with a great test yet. So the diagnosis is really based on the symptoms that you're experiencing and then the features that we see on the physical exam. So the first step to diagnosing Parkinson's disease is to determine whether there's any evidence of Parkinsonism. So you may have heard this Parkinsonism concept and be a bit confused by that. Parkinsonism is just a descriptive term that's used to describe the symptoms of Parkinson's disease. So the most important symptom is what's called bradykinesia, which means slow movement in Greek. So it's slowness of movement, increased muscle tone or rigidity. And we test that by passively moving your limbs around to see if there's more resistance than we expect, and a resting tremor. Those are the three basic core signs that make up Parkinsonism. And then once we establish, yeah, there's Parkinsonism, we have to decide, is this Parkinson's disease or is it something else? Because there are other conditions that can mimic Parkinson's disease. So a lot of what we do as neurologists is look for any evidence that there's some other process going on. So as I said, there's no test. The only way that we can definitely prove that you have Alzheimer's disease Parkinson's disease is to do an autopsy, which in my experience thus far has not been a popular option. MRI and CT scans are generally normal, or they show non-specific changes. So there may be loss of brain volume. Our brains normally shrink as we age, and so you might see that, which doesn't tell you much. In fact, the Canadian guidelines for diagnosing Parkinson's disease basically say that if you have someone in front of you who looks like they have Parkinson's disease, you don't actually need to do any kind of brain scan, because the likelihood you'll find anything on there that's helpful is next to nothing. There are some scans that are called sort of functional neuroimaging scans. So there's some PET scans that you can use in fancy ways to use radioactive labels to assess the dopamine system in the brain. And there's a scan called a DAT scan, which only recently was approved in Canada. These are in terms of the PET scan, it's still mostly a research tool, and the DAT scan is basically no more accurate than being assessed by a neurologist, and so we tend not to use that too often. It's only really useful if, for example, someone's on a medication that could cause similar symptoms to Parkinson's disease, and we're trying to decide, is it the medication or is it Parkinson's, because it can be helpful in that regard. But for most people, it doesn't add too much. So if it's not Parkinson's disease, then what is it? So it turns out that there are quite a number of conditions that can mimic Parkinson's disease. Most of them are other neurodegenerative conditions that are much rarer than Parkinson's disease, but can be completely identical in every way in the first few years of symptoms. Some medications, as I mentioned, can cause symptoms that look very much like Parkinson's disease. These are mostly medications that are used to treat mood disorders, particularly antipsychotic medications, also certain medications to treat epilepsy, and a few others. And then some other structural problems of the brain. So if you happen to have, for example, a tiny stroke in just the right spot, or a brain tumor pushing on just the right part of the brain, you can develop symptoms that look a lot like Parkinson's. But this is very rare, and generally there would be other findings on your physical exam that would raise suspicion for this. So how good are we at diagnosing Parkinson's? So it turns out fair to middling at best. So a study that was done at the Mayo Clinic some years back, where they looked at autopsies and saw, okay, we know what this person has, and then they looked back through the patient's chart to see what did we think they had when they were alive. What they found was that in the early stages of Parkinson's disease, they got the diagnosis right 70–80% of the time. Most of the remaining people have one of those mimics of Parkinson's disease. So when I see someone with recently diagnosed Parkinson's disease, there's a little voice in my brain saying, does this person have Parkinson's? Is there anything atypical here? Are there any features that are unusual for Parkinson's disease that would point me towards a different diagnosis? And usually this shows up within the first 5 years of symptoms, but that same study at the Mayo Clinic found that at the time of death, they still had the diagnosis wrong about 10% of the time. And most of those people had a related condition called progressive supranuclear palsy, which is a different neurodegenerative disorder that can very closely mimic Parkinson's. People are often very, obviously, understandably want to know how their condition will progress over time. This is highly variable between individuals, but in general, the progression is very slow, and we're talking years here. Generally speaking, women progress more slowly than men. None of these are absolutes. These are sort of rules of thumb. The younger you are when your symptoms start, in general, symptoms will progress more slowly. People who have a lot of tremor tend to progress more slowly than people who don't have tremor. And in general, if you wake up one day and things are much worse than they were yesterday or last week, then that's usually a sign that something else is going on in your body. So Parkinson's doesn't worsen overnight like that, but if you have a bladder infection or the flu, or you're under a lot of stress, that will unmask your symptoms and make things look a lot worse than they had been. So it's usually a sign of something else being wrong, and it's a good idea to go touch base with your family doctor and make sure you don't have a bladder infection or something like that, because sometimes, particularly for older people, bladder infections can be otherwise asymptomatic, so you never know. The other rule of thumb that I can tell you is that the rate of progression, while variable between individuals, doesn't change a whole lot for any one person. So if you're on this trajectory where you're going very, very, very slowly, then that's where I would expect you to stay over time. And the flip side, unfortunately, is also true. So what symptoms can people with Parkinson's expect or see? One important thing that I want to mention off the bat before we get into this: everybody has different symptoms. No two people are the same. And no one gets all of the symptoms. So it can be quite a long laundry list, and we're not going to have time to cover all of them today, but I'll go through some of the more common ones, or the more important ones. But I don't want anybody to be under the impression that you're going to get all of these things, because you're not. So first off, there are a few symptoms that occur early on, and these can occur 10, 15 years or longer before any of the motor symptoms start, so tremor, things like that. One of them, in the top left, people can lose their sense of smell. It's not clear why, but it's very common. The people can develop constipation, as sort of in the top right there. In fact, if you're a man in your 40s and you have developed new constipation, that in and of itself is a risk factor for later showing signs of Parkinson's disease. In the bottom left, that picture is meant to represent a condition called REM sleep behavior disorder, in which people start to act out their dreams. So they're screaming, kicking, punching, thrashing, and that again can start 15 years or more before symptoms of Parkinson's start. And in the bottom right, depression and anxiety, particularly if it's new. So if you're 60 and all of a sudden you've become anxious when that was never a concern earlier in your life, that too can be an early warning sign of the development of Parkinson's disease. And these symptoms come on, we think, because the pathology that causes Parkinson's starts in different parts of the brain and then slowly progresses throughout the brain. And so the earliest parts that can be involved might be the olfactory nerves in the nose or the nerves that regulate the bowel function. And so that has led people to wonder whether Parkinson's, at least for some people, may relate to exposures from the environment that get into the body through the nose or through the gastrointestinal system. But that's still active research ongoing. So once people start to manifest clear Parkinson's symptoms, we divide them into motor symptoms and non-motor symptoms. And the ones that I showed you back here basically are a few potential non-motor symptoms. So there's a frequently asked question box here that I don't have tremor. Does that mean I still have Parkinson's? Tremor is one of the more recognizable motor symptoms of Parkinson's, but it turns out that 20 or 30% of people with Parkinson's never really have any tremor. So that's a misconception about Parkinson's disease that has resulted in some delay in diagnosis for some people. So the motor symptoms that we commonly think about for Parkinson's are tremor, as I said. This typically is more prominent at rest. So if it's most commonly starts in one arm, but can start in one leg. And when I say at rest, I mean if you're totally relaxed, your arms resting on the armrest of the sofa, for example, it starts to shake. And then it typically goes away if you pick up a cup or something, it usually will resolve at that point or drastically improve. Rigidity. So this is stiffness of a limb. Like I said, when we move your wrist around like this, we're assessing for muscle rigidity. That can cause pain in some cases. Bradykinesia is really the hallmark symptom. So without bradykinesia, we can't say that you have Parkinson's disease. This is really the one feature that must be present based on the diagnostic criteria. So this is slowness of movement, and this can manifest in many different ways. So this is the reduced facial expression, the soft voice, the small handwriting, the clumsiness of the hands, where it's just hard to do things like tie your shoes, do up buttons, shave, chop food, that sort of thing. Those are all manifestations of bradykinesia. And then postural instability is a later manifestation. So that used to be part of the diagnostic criteria for Parkinson's, but it was removed in the most recent guidelines because if you have postural instability in the first few years of symptoms, it suggests a different problem. So either you have two problems, one that's affecting your balance and one that's causing Parkinson's disease, or you have one of the mimics of Parkinson's disease that causes balance issues early in the disease course. That's for me to sort out, not for you to sort out. Don't worry about that. So those are the most common motor symptoms. I think Dr. Mackenzie is going to talk to you about some other ones that come on with disease progression that have more implications for treatment tomorrow when you hear from her. And then we'll spend some time now talking about the non-motor symptoms. So the analogy of the iceberg is good. The tip of the iceberg, I think, would be the motor symptoms. Those are things that are very visible to people. It's people may notice the tremor, your family will notice that you're talking more softly, but the non-motor symptoms tend to be invisible. And as we've gotten better over the years at treating the motor symptoms, we also know that what drives impairments in quality of life in people with Parkinson's is really these non-motor symptoms that can be many. And people tend to have few of these at the onset, and then as the disease progresses, more and more of them tend to crop up. But again, as I said, nobody gets all of them. So we'll go through a few. The list of non-motor symptoms is just about as long as you are, so we won't have time to go over all of them, but we'll talk about some of the more common and important ones. So depression and anxiety, extremely common. So 50% of people or more, some studies show up to 90% of people over the disease course will experience issues with depression or anxiety or both, and these can be quite significant. Often are overlooked and underreported, and sometimes, interestingly, with Parkinson's can be overdiagnosed in some people because people with Parkinson's have the sort of the masked face, the loss of facial expression. And so before people are diagnosed, it's not that uncommon for their family to think that they're depressed, even though they don't feel depressed at that time. It's just they don't have the animated facial expression. These symptoms can respond well to treatment. So various kinds of talk therapy, counseling, mindfulness, etc., can be helpful. And most people with Parkinson's at some point will need to be on a medication to help with their mood, because if your mood symptoms are out of control, it can make the motor symptoms and other features of Parkinson's much worse as well, particularly anxiety. So often we recommend people treat these symptoms. And other psychiatric symptoms, so apathy can be quite common. So apathy is sort of that lack of motivation, just not interested in anything anymore. This is relatively common, but usually happens later in the disease course. Not always, but usually. And one important thing to note is we tend to associate this symptom with depression, but in Parkinson's, it's not always associated with depression. It can be a primary symptom. We just don't care, not interested, not motivated, which can be quite bothersome, usually more bothersome for people's family. The apathetic person, sort of by definition, isn't that bothered by their apathy, I suppose. Hallucinations can occur, usually visual hallucinations, usually things like bugs. As they progress, you can start to see children, people, that sort of thing. Again, usually later in the disease. Some people will start by sort of having things flit by in their peripheral vision, or have this sense that there's a presence in the room with them when nobody's there, hovering over their shoulder, that sort of thing. Again, these usually occur later in the disease. So sleep disturbances, very common, very troublesome for people. And Parkinson's can affect your sleep in many ways. So one way is that the circadian rhythm, so the body's internal clock that lets us sort of know when it's time to sleep and when it's time to wake up, is out of whack in people with Parkinson's. So levels of melatonin, which is our natural hormone that makes us sleepy, are lower than usual. And that mid-afternoon slump tends to hit people like a bit of a freight train. So we're all programmed to nap in the early afternoon. And culturally, we've just decided not to do that in the West for whatever reason. And with Parkinson's, that drive to nap can be almost overwhelming. And it's okay to nap. It can be restorative. And that can affect your nighttime sleep as well. Restless leg syndrome and obstructive sleep apnea are more common in people with Parkinson's, which can affect your sleep as well. Restless leg syndrome, or I should say, people with restless leg syndrome are no more likely to get Parkinson's disease than anyone else, in case you happen to have RLS. But if you have Parkinson's, you're much more likely to have restless legs. And similarly, people with Parkinson's are more likely to get obstructive sleep apnea, even if they don't have what we consider to be traditional risk factors, such as being overweight or the short, thick neck, that sort of thing that predispose people without Parkinson's. And both of those can affect the quality of your sleep. Some people will wake through the night due to their Parkinson's symptoms. So the tremor comes back overnight, wakes you up, medications wear off, muscles get stiff, and you have pain that wakes you up. Leg cramps, particularly in the early morning, can be relatively common and can wake people. Fatigue in general is very common, and sometimes even if you've had a great sleep, fatigue can be a primary symptom of Parkinson's, unrelated to anything to do with your sleep. It can be quite bothersome. And then REM sleep behavior disorder, as I said before, thrashing, screaming in your sleep, that sort of thing. Obviously, you may not remember doing it, but it will impact the restfulness of your sleep and also of your bed partner's sleep, perhaps more importantly. So other things can affect sleep, but those are some of the big ones. Can people hear me? I just got a note saying the video and audio are gone. Can other people hear me? Great. Okay. So moving along, the autonomic nervous system is also affected by Parkinson's disease. So this is the part of the nervous system that deals with the sort of so-called housekeeping functions of the body. So bowel and bladder function, regulating your heart rate and blood pressure and body temperature, that sort of thing. So lots of symptoms can come up from the autonomic nervous system. So constipation is very common, up to about 70% of people with Parkinson's will have constipation. And as I said, it can precede the onset of the motor symptoms by a decade or longer. And constipation is important, and I'll highlight it a little bit, because if you're constipated, it can also be more difficult to absorb the Parkinson's medications. And so it can really impair control of symptoms. So it seems like a silly thing, but it's one of those things that's important to stay on top of. And I think Dr. Mackenzie is going to talk to you about that tomorrow. The bladder can be involved as well. Urinary dysfunction in Parkinson's usually manifests as frequency, so going to the bathroom more often, as well as urgency. So when you gotta go right now without too much warning. There are medications that can help with this as well. Blood pressure can drop when you stand, making people lightheaded or dizzy. For some people, that it can present as a headache or a feeling of unsteadiness and imbalance. So you want to make sure that you're staying well hydrated when you have Parkinson's, which can be a little bit tricky if you also have issues with going to the bathroom every 30 seconds as it is. But things to balance. Cold hands and feet, very common. I hear people mention that all the time. Nothing to worry about. Again, it's just kind of a nuisance thing. Sexual dysfunction, very common in both men and women with Parkinson's disease. Often not talked about because it's a little bit of a taboo in our culture, but it's very common and very treatable. So if you're having issues with sexual dysfunction, don't be shy about bringing it up. Moving on, so other symptoms people can get: pain, and this can be multifactorial. So if you have muscle stiffness, that can manifest as pain. It's not uncommon for people with Parkinson's to get a frozen shoulder. So one of the things that happens with the bradykinesia is when you walk, the arm on the more affected side tends not to swing when you walk. And so your arm kind of hangs there, and then you get a frozen shoulder. And that's not an uncommon way that people come to medical attention with Parkinson's. They have this frozen shoulder, they've gone to physio, it's not getting better, and then someone realizes something else is going on. They start to see a tremor or the penny drops, and they realize, oh crap, maybe you have Parkinson's disease. And there can be central causes of pain, and by central I mean originating from the brain itself. Pain, as you're probably aware just from general life, is a fairly common problem that many people struggle with chronically, and we don't fully understand how it happens. But clearly, in cases when pain is chronic, it can be, the brain can perceive non-painful stimuli as painful, and that is what we call central pain. Cognitive changes also, unfortunately, will occur in the majority of people with Parkinson's. So if you follow people for long enough, so one study in Norway, for example, found that after 20 years of Parkinson's, 80% of people had cognitive issues. Most people will develop some degree of cognitive impairment eventually. And again, the younger you are when symptoms start, the less likely you are to get issues with this. So that is what I had for symptoms. This is my dog, just as a sort of cute led up to a otherwise heavy topic. So I went through things fairly quickly, and we have lots of time now for questions. So I'll look through the chat box here. So we'll start with that, and I think Alana has some from the email. So guest 688, I know that after a while the medication is no longer able to substitute dopamine. How can we know when the medication is no longer able to do that? So that's a good question. Dr. Mackenzie is going to talk a lot about that tomorrow, but just briefly, the most common medication we use for Parkinson's is called Levodopa, and that's a naturally occurring compound that our body's making all the time. So as we make our own dopamine, the last step before dopamine is Levodopa. The brain then turns that into dopamine. So Levodopa or Sinemet is the most common medication that we use, and that will basically always act as a dopamine supplement. It's just, it becomes more complicated, shall we say. And I'll leave Dr. Mackenzie to talk about that tomorrow. But it always will work for that. The issue is that as the disease progresses, some of these other symptoms that I talked about and some other ones that I haven't talked about are not related to dopamine. So there are other brain cells and other chemical messengers involved that drive some of these other symptoms. And so and dopamine doesn't help those. And it doesn't matter when you started the therapy with dopamine. We used to think that you had to wait as long as possible because if you started it sooner, it would make these other things worse. We no longer think that. It just turns out that there's a lot of symptoms that are not dopamine related in Parkinson's disease. I'm not sure if that was clear or made things muddier. Okay, is Tourette syndrome related to PD? Since Tourette syndrome is a chemical imbalance of the brain, would PD develop some symptoms similar to Tourette's? Actually, they're not related, which is good. But you know, there's a lot of mood disturbance that comes along with Tourette syndrome, similar to PD, but they're caused by different things. But there's no relation between those two conditions. And then can you say more about treatment for urinary frequency and urgency? So Dr. Mackenzie is going to talk about the treatments tomorrow, but there are different medications. So it depends a little bit on what the problem is that you're having. So the most common thing from Parkinson's, as I said, is basically an overactive bladder. So you get more frequent, more urgent urge to pee. So there are medications that basically calm down the overactive bladder. So we have to be a little careful with Parkinson's because some of those medications can have memory side effects. And for people who are already going to potentially have cognitive issues, we have to be a bit careful. So there are a few that don't, and we tend to prefer those for people with Parkinson's. Unfortunately, those one or two better drugs are not covered by pharmacare, and it can be a little bit expensive. So that's a realm for advocacy. And then if things are really not improving, then you can actually use Botox, the same stuff people use for their wrinkles, injected into the bladder by a urologist, and that can calm the bladder down. Some people have more problems retaining urine, and it's harder to get the stream going, harder to empty the bladder, and that has sort of different treatments. Often in men, that would be more related to prostate issues. So sometimes it can be tricky to know exactly what's causing things, and so I often send people to a urologist for some testing to try to sort that out. Some natural sources of dopamine. The only one that I'm aware of is there's a plant called Mucuna pruriens. I know Dr. Mackenzie is going to talk about this tomorrow, so I'll just say very briefly, it's been studied as a low-cost alternative for the use of Sinemet in the developing world. In North America, it's substantially more expensive than the prescription drug, and it works. The one issue is that as a supplement, it's not as carefully regulated as the pharmaceutical drugs, and there have been studies in North America that commercial preparations contain between 5 and 150% of the levodopa that it says on the label. So from one batch to the next, the dose might be radically different, even though you're taking the same amount. And so for that reason, as well as the expense, I usually don't recommend it. There's really not much benefit to it over taking the pharmaceutical thing. It's exactly the same compound. It's just one is a plant extract and one of them is made in a factory, but they're exactly the same. And there's no long-term data with Mucuna to show that it's any better than anything else. Any supplements used to help with symptoms? Unfortunately, every supplement that has so far been studied in humans has been found to not have any benefit for Parkinson's disease. Having said that, things like magnesium can help with leg cramps and constipation. There are different types of magnesium. Some are better absorbed than others. And basically, the less well absorbed the magnesium is, the more like a laxative it behaves. So it will help more with constipation and less with leg cramps. And there's some suggestion that people with Parkinson's may be more vitamin D deficient. So some people will recommend a vitamin D supplement. But unfortunately, there's no other supplements that have been shown to be beneficial for Parkinson's. So my brother has MS. Is there a possible relationship between the two diseases? As far as we know right now, no, fortunately. It's just bad luck, I guess, in the family to have both. Has lithium ever been used to treat PD? So I have seen some naturopaths prescribe small doses of lithium. I think that this is extrapolating from animal data around lithium having neuroprotective effect in mice. One concern that I have about that is that lithium can actually cause Parkinson-like symptoms, and as far as I know, it's never actually been studied in humans. And so you have to be a little bit cautious around anything with animal data, because the issues are that animals don't get Parkinson's disease. Generally speaking, we poison them with something that kills off one of the populations of neurons to give them similar symptoms. But and any supplement that's been used in those animal models that subsequently been studied in humans hasn't benefited, which makes a bit of sense because you're studying two different pathological processes. So we have to be a little bit cautious with the supplements. Having said that, no supplements have ever been shown to be harmful as far as I'm aware. But I would be a bit cautious with the lithium personally. Elaborate on other symptoms that are often found with PD but not directly due to PD. So one of the issues is that, you probably have the idea that Parkinson's can cause many different symptoms. And one of the challenges is always trying to figure out, is it the Parkinson's or is it something else? A good example is bladder issues, particularly in older men, because you're entitled to have a enlarged prostate as well, which could be contributing to the urinary symptoms, as well as Parkinson's disease. Sometimes it's hard to know. And pain is another common one. So again, arthritis is extremely common, and you can have arthritis pain that's not directly related to Parkinson's that may be worsened by the Parkinson's because your muscles are stiff and pulling on the joints in an abnormal way, and left and right are not perfectly in sync anymore, so you're kind of moving in a different way that might put different stresses on your joints and things that might, cause arthritis pain to flare up, or more likely to get tendonitis or bursitis or things like that can cause pain. So the symptoms are many, and if there's anything specifically that you were wondering about, I'm happy to elaborate on it, but it's a bit hard to be totally exhaustive. What are the most common cognitive issues that can develop? So the pattern of the type of cognitive impairment people with Parkinson's get is issues with recall. So we all get this to some degrees. We get older where the word is on the tip of your tongue and you can't quite get it, and then it comes to you at 3 o'clock in the morning. Parkinson's takes that and makes it worse. Visuospatial issues are common as well. So difficulty with the brain processing where objects are in relation to one another, which can have implications for driving, right? If you have trouble figuring out how far away that parked car, that pedestrian is from you, and correct your speed accordingly, that can have implications. Eventually, people will progress to more significant dementia with issues with memory that can look a lot like Alzheimer's disease down the road, unfortunately. But not everybody gets to that point, and it usually takes a long time to get there. And also just to point out, as I said, it's normal as we get older, and by older I mean over 40 or 50 years old, to have issues with word recall. So with the words on the tip of your tongue, it's normal for multitasking to get harder, and it's normal for cognitive processing to slow down. What we have to do is watch for when those things start to actually impair your ability to function day to day, that we considered a significant cognitive change. Comment on CBT. So cognitive behavior therapy is a well-established treatment for depression and anxiety, and it's just as helpful for people with Parkinson's disease. Unfortunately, it's one of those things that you have to pay for out of pocket, or your extended health benefits might cover, but it can be quite effective. I don't believe it's ever been specifically studied for the treatment of mood issues in Parkinson's disease, but anecdotally, people find that it's helpful. NAD as a supplement to help with Parkinson's. Again, lots of supplements are out there. I'll just say this as a blanket statement for them. None of them have been proven to have any benefit for people with Parkinson's. Many of them are recommended based on, again, animal studies, but again, when anything that's been then studied in humans has unfortunately been found to be ineffective. It's not to say that people aren't trying, but part of the issue, as I said, is that they're being studied in the wrong model to begin with. Can you take too much levodopa? So yes, but only insofar as the more you take, the more likely you are to get side effects, and nausea being a big one, lowering your blood pressure, another one, hallucinations sometimes are side effects, and that goes for Mucuna equally because it's exactly the same drug. Taking more levodopa will not affect disease progress, will not affect symptoms you develop, will not affect later response to levodopa in any way. We're pretty confident about that now. There's still lots of stuff out there about that because that's what we used to think 10, 15 years ago. But now that we have better data, we're not concerned about levodopa any longer. There's some issues with hearing me. Hopefully, can people hear me okay? I see lots of comments that they can't. Okay. Either way, this is recorded, so if you miss some of the answers, then you can go back and just listen to the end of the presentation. Is mercury from tooth fillings thought to play a potential role in PD? No, it's not. The further sessions be available by streaming? Yes, they will. Okay, from first tremor to more significant issues like cognitive deficiencies, is there an average time it commonly takes? Not really, actually. People with tremor are less likely to get severe cognitive issues than people without tremor, but otherwise it's highly variable. Generally, if people start to have significant memory issues within the first year of symptoms, then we would most commonly say that person actually has a related condition called dementia with Lewy bodies, but that's kind of a sort of semantic academic distinction between the two. But the cognitive issues really can start at any time, unfortunately. In general, the younger you are when symptoms start, the less likely you are to get cognitive issues, and they tend to come on later. But they could happen at any time, unfortunately. Okay. Alana, were there any other questions that you had?
Yes, I have 3 questions that were submitted by David. So if I could ask those, please.
Sure.
So the first question is, what motor symptoms does levodopa help? Hello, Dr. Squires.
Sorry, you're breaking up a little bit, Alana. Yeah, I can. Yeah.
What motor symptoms?
I heard something.
What motor symptoms does levodopa help?
So levodopa is most reliably helpful for the rigidity and bradykinesia. And we basically say that it makes things 50, 60, 70% better. Some people find it more effective than that. And usually helps well with the tremor, but about 20% of people with tremor need very high doses of levodopa. So it will work if you push the dose high enough, but then you have the risk of other side effects. So it should help with walking, it should help with balance to a certain degree. Freezing, which I think Dr. Mackenzie is going to talk about, which is when you tell your feet to move and they just stick there, responds up to a certain point. And then there are features of freezing that are not related to dopamine, so that it can become resistant as the disease progresses.
Okay, thank you. The next question is there any benefit or harm in delaying medication?
No. No benefit to delaying. The harm is basically depriving yourself of the benefit of the medication. So for me, my personal philosophy of medication is that the treatments for Parkinson's disease are all symptomatic treatments, so they're effectively quality of life drugs. I'm conscious that taking a medication has a negative impact on one's quality of life. And so the time to start medication is when the nuisance of taking the medicine is outweighed by the benefit you're getting. My red line is if people come and tell me, I'm struggling at work, I'm having to give up hobby X, Y, or Z, canceling this trip because I can't keep up, I'm having trouble swallowing, my balance is bad. When those things happen, that's when I start to suggest more forcefully, shall we say, that you should consider medication.
Okay, and one other question. Are there any recent findings that help with slowing down or stopping the progression of PD?
Yeah, so this is going to be discussed in future talks as well, but the only thing that we know of right now that slows down the progression is exercise. And there's going to be a whole session where our physiotherapist talks about that. There's no great research on how much exercise or what the best exercise is. We generally recommend 30 minutes a day. And my personal bias is that if there is a best exercise, if you don't like that exercise, you're not going to do it. So you're much better off just finding something that you like to do and sticking with that. And it's good to do some cardio and do things that will focus on core and leg strengthening, because those will help maintain balance over time as well. Okay. Are there any other emailed questions, Elena, or shall I go back to the chat box?
No, there's just a few more I see in the chat box.
Okay, all right. So what can be diagnostically done to diagnose Parkinson's disease? So as I said, the best thing we have right now is a good history and physical exam, and then monitoring over time for features that emerge that we don't expect to see in Parkinson's disease, or that we don't expect to see so soon in Parkinson's disease, for example, like falls. The holy grail of Parkinson's, one of the holy grails of Parkinson's research right now is actually coming up with an accurate diagnostic test that can figure out before people are dead what they have, but we're not quite there yet, unfortunately. And most of these other fancy things you talk about are mainly used for research, or they're no better than being examined by a neurologist who has experience with Parkinson's disease. That's a bit disappointing. Any promising research? So lots of studies are ongoing. So there's lots of different treatments being studied, various different strategies. They're starting to look at personalized medicine approaches for Parkinson's disease. So taking those people who have a genetic cause, where presumably we know why they have Parkinson's disease, and using a drug that tries to fix the problem, that's caused by that genetic change. But so far, most of the studies right now are sort of relatively early on, so more in the phase 2 series of is the drug safe as opposed to is it effective. There was a long drought of Parkinson's disease treatment, but now there's actually quite a lot of stuff going on, which is promising. So alcohol, everything in moderation. Alcohol in and of itself does not have any effect on the progression unless you're drinking very heavily, in which case very heavy alcohol consumption over many years is toxic to the brain as well and can affect your balance. And of course, if you already have a bit of balance issues from Parkinson's and you are drunk, your balance is not going to be better, and so you're higher risk of falling, which is something that we try to avoid at all costs. So small amounts of alcohol are okay, just be very, very cautious. Exercise-induced dystonia. Yes, so dystonia, for those who aren't aware, is basically a abnormal contraction of a muscle group. And in Parkinson's, it's the most common things would be curling of the toes or sort of inversion of the foot like this. And that is fairly common with exercise. It's treatable. It usually responds to Levodopa and the other Parkinson's medications. And if it doesn't, then we can treat that with Botox or similar injections. genetic testing a helpful thing to do if nothing really helps prevent PD, or can knowing be an advantage by starting exercise sooner to increase dopamine in the brain, as an example? So that's a great question. Right now, where we're at, the genetic testing is really more, I guess, for any given individual, is more kind of an academic thing. It's interest and perhaps being able to, people often wonder what's the risk to my children of me having this disease. And so if you have a genetic cause, so for example, if you have a mutation in a gene called LRRK2 or GBA, which are the two most common genetic causes, then those are dominantly inherited genes. So you have a 50% chance of passing those on to each child. And so it might be, some people would want to know and some people would not want to know that. So that's personal. And you're right that right now it doesn't affect the treatment at all. But hopefully it will in the future. As I said, there are these personalized medicine approaches where they're taking people with GBA mutations, for example, and trying to treat them with drugs to fix the problem the mutation causes. But for now, it's kind of more done for interest, which is also, it's not covered by BC Medicare, but you can get a panel done for the 18 most common genes at a lab in the US for about $250 US. So it's not prohibitively expensive, but it won't change anything. And some people would like to know that that's in the cards earlier so they could start exercising. Other people really don't want to know because it would sort of take over and they'd be very anxious about it. So that's a kind of a personal decision. Obviously, all of us should be exercising regularly anyway, just for health in general, our general health as well as our brain health. But if it would motivate you more, then sure. Alcohol use, so I just commented on that. Too much alcohol per day. So generally, I think that's 2 drinks for women and 3 drinks for men, no more than 15 a week for men and 10 a week for women. And there should be some alcohol-free days, essentially, are the current guidelines. And, you know, considering ml, I think 6 ounces of wine and 16 ounces of beer is one drink. Those guidelines are readily available if you search on the internet. Do you recommend diet for the mind as something that can slow progression? So the MIND diet is sort of a variation on a Mediterranean diet. There have been some studies actually that do show that it slows brain aging in general for the people who most closely adhere to that diet, which is basically more plant-based foods, berries, nuts, healthy fats like olive oil, small amounts of wine, that sort of thing, less meat, more plant-based, does seem to help slow brain aging. I'm not aware of any specific research for Parkinson's, though there may well be, but it does seem to slow brain aging for healthy people, so it probably would help with Parkinson's disease. And CBD for the symptoms of Parkinson's disease. So the jury's still out on that one, I would say. There haven't been too many studies published, and the ones that have been published, the results are contradictory, and on both sides of the equation, the quality of the studies aren't great. So short follow-up periods, most of the studies that showed a benefit were people who are sort of habitual users of cannabis to begin with. Anecdotally, I would say the majority of my patients have tried CBD and almost all of them stopped it because they didn't find it helped. And those that kept on with it found that it helped with pain and sleep, which are areas where it does have some more established utility, but I haven't seen anything like the dramatic benefit that you see in like YouTube videos for Parkinson's, for what that's worth. Velvet beans, that I'm not sure, but it might be Mucuna. Let me just look here. Yeah, velvet beans are Mucuna pruriens, basically. Mucuna is the Latin name for it. So I spoke about that a little earlier. All right. So last call for questions. I guess we've got about 5 minutes. Otherwise, Dr. Mackenzie is going to talk to you tomorrow at 11 a.m. about the treatment for Parkinson's. So any questions that I didn't go over with that, she'll be more than happy to answer as well. Commonality in what people with PD can expect. So unfortunately, the only thing that we can really guarantee is that symptoms will progress over time. People with Parkinson's tend to develop more non-motor symptoms with disease progression. But it's very difficult to say with any certainty what symptoms you'll get, how things will progress, how you'll be in 10 years. It's very difficult to guesstimate, essentially. I have a sleeping disorder. What medication is good for sleeping that doesn't have effect on memory? So it depends on what the type of problem you're having with sleep is. And there are many different types of problem, and the treatments can be quite different. In general, if it's insomnia, the first line treatment is cognitive behavioral therapy, actually, at this point, meditation, mindfulness, and then there are some medications, but it's complicated, essentially. And what's my opinion on deep brain stimulation for PD? So deep brain stimulation is a very effective treatment, but is generally only used for people with more advanced Parkinson's, for whom medications are not reliable enough. So either people are having side effects from medicines, the medication's not lasting long enough, they're having dyskinesias. One important thing to note about deep brain stimulation is that it's basically just electric levodopa. So if a symptom doesn't get better with levodopa, it won't get better with DBS. So that's one important thing to remember. But generally, it's only people with advanced disease, and only about 1% of people actually worldwide end up getting deep brain stimulation, interestingly. What percent of PD patients end up in wheelchairs? It's a high percentage. I don't know the number offhand, but I think if someone with Parkinson's lives long enough, which can be 20, 30 years in some cases, then most people would end up in a wheelchair towards the end of their life. But it usually takes people a very long time to get to wheelchair-bound state. So if you're coming to a new diagnosis workshop, I would estimate that you have a very long time, in the range of 5, 10 plus 15 years, without needing to worry about a wheelchair. But again, lots of individual variability there. Okay. Thanks everybody for.
All right, so yes, I guess I was just going to say thank you, Dr. Squires, for such an informative presentation. And thank you so much for answering all of our questions. And thank you all for attending today and for participating with all of your questions. Some really good questions there. And again, if you have some questions that were more related to treatment, Dr. Mackenzie can probably talk about that more in depth. So please bring your questions tomorrow as well. And just a reminder, we also have a final question and answer period on the very last talk of the series. And that one is a 30-minute question and answer period.